All right. It is my great pleasure to finally introduce Dr. Andy Fine, who has come all the way from Boston to spend some time talking with us about the challenges he faces in pediatric emergency medicine, the brilliant ideas he has to solve them. And then we're going to pick those brilliant ideas apart, and then we're going to make them even better, right? Because we are going to have please today, please, you know what I want. Thank you. We're going to have flying monkeys. So the more creative, the better. If you've taken snacks, you owe me a flying monkey. I've watched you. You will be speaking if you have taken snacks. Andy will explain all about what he does. Thank you for being here and being patient. So
thank you so much. Thank you all for coming. Thanks, Amy, John, Jean, everybody that I met with today. It's really been incredible to come out to Ann Arbor. The last time I was here was 1994, which is the year that my nephew was born. So he's 29 now, so he's probably older than most of the people in this room. But at the time, my brother-in-law was an ECMO fellow, and my sister was living here as well. And she gave birth to Sam. So I came out and I haven't been back since. So it looks a lot different. But everything I've seen is so impressive, and even more so, just the hospitality you guys have given me has been so amazing. So thank you. Go to the first slide, please. I want to tell you a little bit about what I do. I'm a pediatric emergency medicine doctor. I work at Boston Children's Hospital. First and foremost, I'm a clinician. I take care of patients in the emergency department. I love taking care of kids. I love working in the ER. I hate when bad things happen to kids, especially in the healthcare environment. And so I've just sort of tried to dedicate myself and the work that I do to try to make the world better for patients while they're in the ER at least. So the other ways that I spend my time is I teach medical students. I teach residents, I teach fellows, I mentor some residents and fellows in research projects, mostly around using digital innovations to improve clinical care. Some of the work we've done in the past is we've tried to incorporate real-time epidemiology into clinical decision-making. So the example with that would be, let's say you wake up one day and you have a sore throat and you're thinking maybe it's group A strep, which could be treated by penicillin, whereas most pharyngitis is actually viral and gets better on its own. And the last thing you want to do is take an antibiotic and give yourself another problem. And so there's this score called the Centaur score, which takes 4 elements: fever, absence of cough, anterior cervical adenopathy, and exudate. And the more of those symptoms you have, the more likely you are to have bacterial strep and get treated with antibiotics. And so what we did was we took a large database from CVS Minute Clinics, and we were able to look at all the patients that had certain symptoms, and we were able to then incorporate what's the incidence of strep throat over the last week in the community. Conceivably, if let's say your Centaur score was 2 and the recent incidence is low, then your risk of strep would be lower than if your Centaur score was 2 and the recent incidence was high. And so we developed models around trying to improve the predictability of strep throat given real-time epidemiology. We did that with some other diseases as well. One of the other projects we worked on, I think you guys have already covered in this class, was trying to reduce boarding times in the emergency department. I think you did a session on left without being seen. And one of our projects was trying to predict who's likely to be admitted to the hospital right when they show up in the ER, sort of looking at based on their medical record number, being able to say right when they show up at triage, how likely they are to be admitted. And within about 20 minutes, we had a pretty good idea of whether or not someone's going to be admitted. And we sort of tested and validated that in different situations. But I want to talk to you guys about a different project that we've worked on more recently, and that's physician burnout and the role that documentation may contribute to that. So we can go to the next slide. I only have about 3 or 4 slides, and then it'll be a discussion. I borrowed the figure from AHRQ, but clinician burnout is very real. The Surgeon General, who I think you said he met recently, in his 2022 advisory, said that clinician burnout is one of the main problems facing healthcare today, and it results in reduced satisfaction of clinicians. It leads to medical errors because clinicians who are burned out may not be paying as attention quite as well as they should be, and overall provides a big strain on the system. In a 2018 survey, they discovered the electronic health record. They decided was, in the survey, was sort of the leading pain point in clinical practice. And for for all of us when we go to see our own primary care doctor, we go to the emergency department, they're like, the doctor's sort of typing as they're talking to you, do you wear a helmet? Do you wear a seatbelt? How many drinks a day do you have? That sort of thing. And they're not necessarily looking at you, and it's all trying to be efficient, trying to make sure you can get all your documentation done, because if you don't get it done during the visit, then you're staying late and then you're missing out on the rest of your life. And so in some surveys, physicians send as much as two times the amount documenting as they do facing patients. And that's not why most people go into clinical medicine. They want to be interacting with patients. They don't want to be doing a lot of the documenting tasks. And the last point on this slide is that up to 50% of clinicians experience burnout at some time in the past year. Next slide. So I just want to discuss some of the non-patient facing tasks that clinicians face. And this is just in the emergency department. Primary care doctors and specialists have a whole nother set that some of you have been working on with regard to like the inbox of all the messages that are coming in around your patients. So there's the clinical note for the visit. That's where I'm writing. I'm usually free texting what the story is. For example, this is a 12-year-old who comes in with vomiting and abdominal pain that's gone on for 24 hours. There's no prior surgeries. I'm putting in all the relevant pieces of the history and physical. And I'm doing the first part of that during the first part of the visit. I'll examine the patient. I may come back and do more of it later as I start to get tests back. There's something called medication reconciliation. Are you guys familiar with that? I'll show you an example. Actually, let's go to the next slide and then we'll come back to this one. There's an example of I de-identified. There's a patient I saw last week who was in the emergency department for 18 hours getting worked up for a swollen leg. And this is a partial list. I couldn't fit all of them on one slide here, but there's a partial list of their medications. And so it's another task for the busy clinician is to try to figure out which of these medicines matter, which of these medicines does this patient have to take during this stay. So, Tylenol, it's probably not that important if they get it. But if they have a seizure history and we forget to give them their seizure med and they came in for a swollen leg and now they're going to status epilepticus, that's a big problem, right? So being mindful of which medications are important that we administer while they're in the ED. Let's go back one slide again. So there's medication reconciliation. There's discussion with consultants. And when you call the consultant, they want to hear the story. So I sometimes will have a patient where I'm calling 2 or 3 consultants because the complaint may be non-specific. So I may have to call a rheumatologist, a gastroenterologist, and a surgeon on the same patient. And each time I'm telling the same story to the clinician, maybe slightly different because the question I want them to ask might be the answer I want from them might be a little bit different. But each time I'm talking to them, I'm having to say the same story. So that usually involves looking up to see who's on for that service, paging them, waiting for them to call me back. When they call me back, am I available to take the call, or is my phone going to ring through and then I'm not available, and then I call them back and now they're in the OR or something else. So it can take a while to get that stuff done, which partially explains why the visits in the ED can be so long. Also discussion with the primary care, trying to get collateral information. Let's say a young patient shows up with bruising on the face and they're 6 weeks old and I'm concerned about non-accidental trauma or child abuse. I want to talk to the child's pediatrician to find out if there are other concerns. So that takes time. Reviewing the medical record for the patient. So EHRs are great, right? We have all the information available to us at the point of care. It used to be you'd have to call and get the file, and the file would show up and you'd sort of rip through the paperwork trying to decipher the writing. Now it's all legible, but there's a lot of it. Sometimes these patients have thousands of documents and you're trying to figure out which ones you need to look at. Filling prescriptions at discharge. I got to go sit back down at the computer and make sure I'm putting in the right medication, the right duration, sending it to the correct pharmacy so that the patient can pick it up. And then discharge instructions for the family. I think is really underestimated how important that is, because we see a patient, everything's done, hooray, the patient gets to go home. And then all of a sudden we give this very generic form to them that doesn't really tell them exactly what's happened during the stay, and they may come back the next day with a fever when really we knew they were going to have a fever for a couple more days. We don't necessarily need them to come back. So is there a way that we could help the clinician come up with something more customized? And then on the other hand, when patients aren't going home, they're getting admitted to the inpatient service. Again, we're paging the inpatient team, waiting for them to call us back, and then signing out everything about the patient, what's happened to them prior to arriving to the ER before they go to the floor. I think there's one more slide. And then if we want, we can come back to that one. Is that the next one? Yeah. So 2 quotes. First one, one of the guys I work with says, if I didn't have to document, I would have the best job in the world. A lot of us feel that way because we're spending so much time doing documentation. What we really want to do is interact with our patients, help them and get them on their way. Documentation is super important, not just for billing, but actually as a way of communicating with other clinicians, with the primary care doctor, with the person who sees the patient on the next visit, try to understand what you were thinking when you saw them. So it's a super important part of the job. It's just not the most fun part of the job. And then this quote from AMA president who said, "It is clear to me that artificial intelligence will never replace physicians, but physicians who use AI will replace those who don't." And so it's for people like me and people who work in the emergency department, we're trying to figure out how can we use artificial intelligence to try to help us with some of these tasks. Next slide. So as we think about how we can leverage artificial intelligence to mitigate burnout and reduce burnout, some factors for us to think about are maintaining patient privacy. So we can't necessarily just go onto like an external version of ChatGPT and feed our patient data into that because that may not be protected. We're familiar with the hallucinations. ChatGPT has been known to an artificial intelligence to make things up. And, if you're planning a trip to Chicago and you say, what are the 7 best places to visit? If it tells you something that's in Indianapolis, that's not going to be life-threatening. But if ChatGPT tells us to manage a patient in a certain way and it gives us the wrong medication or the wrong dose, obviously that's a big problem. And so how much can we allow ChatGPT to sort of guide us without close observation? And then another thing to think about, and there are many more things to think about, but one of the other things to think about is, do we want to add a whole another set of tasks to clinicians? Like I said before, if ChatGPT makes a hallucination that we act on, that's really bad. And so a lot of clinicians feel like we need to, actually, if we were to use artificial intelligence, really need to check everything very, very closely before acting on it. I think I'll pause there. See if people have questions or reactions. And then at some point I can talk about some of the work that we've started to do in this area too.
So we're going to start. Angela, you're in the corner. You just know I start corners, but I guarantee that you said something that was not a word or a concept known by everybody in the room that you take for granted.
Okay.
So I'm going to ask you because I know that you will be willing to ask a question without feeling uncomfortable asking. So what is something that was said that you didn't understand?
I think some of the research that actually I've looked at from Amy, I read your paper on predictive modeling in the ED, and I think the use of AI is really incredible when assisting physicians, not replacing them. Have you, seen predictive modeling or used artificial intelligence and it's gone really well or gone really poorly? Have you tried these methods? Do you know if they've been implemented, or is that something that you're looking, or more providers are looking for it to pivot to?
Yeah. I think what we're trying to do is trying to balance, can I use it for sort of non-clinical decisions, like for patient handouts, something where it wouldn't necessarily be me giving an intervention, prescribing a medication, or dosing a medication. But are there other areas where it can reduce my clinical burden to help patients? So one of my colleagues had an interesting use case of artificial intelligence where he was taking care of a patient. I mentioned this to a couple of people earlier today, I think, but he was taking care of a patient who we've had probably around here too, but in Boston, we've had a lot of recent immigrants who started, some of them in like Dominican Republic, got on a boat to Central America and then walked for months to a year to the border got over the border into Texas, and then some of them were bused or flown by Governor Abbott up to Boston and New York and other places for like safe havens. And so we had these families showing up in droves, like at the ER, looking for a place to stay for the night until they could sort of get settled. And so we had these protocols. We'd have like one doc just sort of doing medical screening exams, saying like, the family would say, oh, I have no medical problems. I'm ready to, I just need a place to stay tonight. But this one kid who's like 9 months old had this like really, really bad cradle cap. I'm sorry, it was tinea, had really bad ringworm, which can be treated with a medication that we don't, like the ER doctors never prescribe it because it can sometimes cause some liver problems. And it's dosed really weird, and it's dosed in all these things. Like when you're doing primary care, you can do it. But so not only that the patient, I think this particular patient spoke Haitian Creole, which is not that uncommon for some of our patients. So what he did was he said, give me, he said to ChatGPT, his input was something like, provide for me discharge instructions for a 9-month-old on what the dose should be for griseofulvin, which is the medication that we don't like to give, and how to manage ringworm in this age group. Okay, so he got it in English. He read through it. He's like, oh, wow, that's like much better than I could do because I never like prescribed this medication from the ER. And then he said, okay, now translate into Haitian Creole. But he didn't stop there. Then he said, now back translated to English. So he could sort of like check to see what was lost in the translation. And that seemed like a pretty good use of it, that, he had to check the dosing of it to make sure, but that seemed like a pretty decent use of it. I think there are other groups that are doing other projects. One thing that we're doing on the research side is we just finished a mixed method study where we basically took the way it works is if I'm working in the ER, I'm working with a team of residents and fellows, and they'll see the patient first. They'll basically do their note, and then I have to do a little attending note at the bottom of it that says like, I've seen the patient, I agree with the resident's assessment. Briefly, it's a 14-year-old with right lower quadrant pain and tenderness. We think this is most likely appendicitis or ovarian torsion. I sort of summarize everything I'm thinking. And so we said to ChatGPT, can you take the resident note, which is this long, and condense it to an attending note that's like 3 or 4 sentences. It gives the chief complaint, the pertinent positives and negatives, the important medical decision making, and then what the next action items are. We had to do that, and then we asked 10 clinicians in our department to sort of compare the note that they wrote versus the one that artificial intelligence wrote to sort of see which one they like better. So that was pretty interesting. I don't think that's ready for prime time yet, but we had to do that. And then we also had to do a summary of the visit that we could give to the patient and said, like, at 8th grade level, summarize what's happened so far in the visit so that the family can understand. Because if you've ever been in an ER, you get your discharge instructions, you're like, what happened? No one ever told me like, what are the results and what do I do next? It's probably they told you, but like you've had some medicine and you're not really sure what's going on. So just like summarize it at 6th grade or 8th grade reading level. And then the last thing we did was we had to provide a structured handoff, and said do it in an IPASS handoff. IPASS is something that a lot of ERs use to hand off a patient from the ER to the floor, and it's an acronym that basically say if the patient's stable or not, what the past history was, what the action items are, and was sort of a summary of the labs, and it's like a very structured format. So we said, ChatGPT, okay, take that resident note now and give me an IPASS handoff that I can then use to summarize the patient. We thought, well, maybe we could even send that to patient doctors. That's some of the active work.
Some doctors recently have been using the medicine text-to-speech feature so they could use that typing burden. Have you tried doing that? Like, is it accurate or?
For text-to-speech?
Sorry, speech to text.
Oh yeah. That's interesting. I just have to tell one little sidebar is I forgot to mention that my wife's parents met at University of Michigan, and my father-in-law was an electrical engineer and he got his PhD here. But then he went to MIT where he invented a machine that does text to speech, which is what I thought you were talking about at first. And it was used by Stephen Hawking for many, many years, which is pretty cool. So Stephen Hawking's voice was that of my father-in-law. Anyway, so we do use we do dictate. And I think that does help in terms of not having to type the note, but you still have to dictate it. So that's quite helpful. I've found that I don't know if do you use it at all? Dictation?
No, I've just noticed some doctors using it, so I was wondering if it's implemented in your department.
I dictate almost all the history of present illness and the medical decision making, and then I click a lot of the other things. There's macros and clicks that we can use. But you should try it because Microsoft Word has a really good version of dictation. So if you ever want to try it, it's actually
I want a
quite accurate.
generational test, and I'm going to ask people on Zoom to vote as well. So how many of you dictate texts versus type long text versus why would I ever send a text more than 3 characters?
Okay, let's do a generational one, but then I have a follow-up.
Okay, so how many of you will actually dictate a multiple sentence text?
Sometimes.
Usually. How many of you just don't send multiple sentence text? So how do you communicate? Because you don't talk on the phone, right?
It's either, if it's a work thing, it just goes to email. I will send multiple texts. Like the period that sentence gets sent.
Oh, you
And then
Ding, 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 ding. So if you're a quad, each text is a quarter, so actually.
Parents quarter.
Okay, how about on Zoom? Are people actually typing text?
Right now.
Yes, okay. Sorry, I didn't mean to interrupt, but I found it fascinating that at some point I realized I could just talk to my phone, and then I started seeing other people, and there are people under the age of 30 who will speak to their phones.
So.
Okay,
I have a
Marina.
follow-up question, and let's ask the same question. And so by text, I don't mean text message. I like, if you have to write an email, if you have to write an introductory paragraph to your paper, whatever it is. So how does that break down, typing versus dictating? For people who are native English speakers and people who have an accent. And have names that Siri has never heard of. I'm actually need an
Well,
answer.
does anyone-
Googling is enough.
What about writing it out? Does anyone do that?
Right, Ian?
Ooh, like the swipes.
No, like writing with a pen and paper.
Oh.
So like a first draft of an outline or.
Anna, go ahead.
Yeah, I just have a comment, because as you mentioned, the voice to text feature, like as you're having an appointment, I remembered the first time that I ever experienced that as a patient. This was at a clinic that I was going to regularly, and it was actually really nice to experience my doctor saying, one moment, he has his microphone right here, and he's speaking, and he's like, Miss Buck is age, whatever, experiencing this, and to hear him speak my complaints and my stats and everything in front of me, it felt really empowering because I knew what was going into my chart. Whereas when he was typing, I could see it afterwards, but there's always that thought, are there 2 versions of the notes? So I think maybe one positive aspect of the speech to text is maybe it can help create a sense of trust between providers and patients, and kind of ensure that patient-centered strength-based language is used. Yeah, I enjoyed it.
There's also a safety component in that too, because you might have heard him say, or your doctor hear her say, left-sided pain. You say, actually, it was right-sided or something like that. So there's an opportunity to nip it in the bud, because the doctors get it wrong a lot when they're, from the time that they are in the room to the time they go back to the charting areas, oh, is it the left ear or the right ear? And sometimes it may not matter that much, but sometimes it might make a big difference. So
It's that disability justice slogan of nothing about us without us. It's keeping the patient involved in their own care.
right.
There's a question in the chat. Has dictation created challenges in terms of pulling or reporting on data for the, and somebody added a new chat, so it scrolled on me, hold on, of pulling or reporting on data for the development of predictive models?
Oh, so natural language processing into the predictive models, is that?
I'm not sure. Let's see.
Yes, correct. That's what I was asking.
Mute yourself. Yes, please. Go ahead and ask directly.
Yes, thank you. Yeah, that's exactly what I was asking about.
Oh, yeah, so there are people working on it. I think it's like maybe next level a little bit because the natural language processing is I think it's a bit harder to process, but I think that would be the next level. There's certain tools in Epic and which we don't use yet, but we're about to, and other electronic health records that are really made to pull out sort of prefabricated words. And there are people that are working on the natural language processing part of it. So I think it can be helpful, but I think we're not at the point now where we're able to use that so well. But I mean, artificial intelligence would be a great way to try to figure out which words are being used more. Somebody is saying, oh, Max was saying earlier today that one of the predictors for admission, they had come up with some sort of predictor for admission, and then they realized that if the patient brought the iPad with them to the ER, then they were less likely to be admitted because it was probably a less serious complaint if they had time to run and get their iPad before they showed up at the ER. So that was sort of funny. We'd call it the suitcase sign, where the patient shows up in the ER with a suitcase. They're highly likely to be admitted because they know they've already packed their stuff to stay for a couple of days.
Comparative effectiveness analyses being done to understand the impact on physician burnout with AI?
Have we done analyses yet?
I assume probably not yet, but are any in process that you know of to understand whether this is creating any more work, as you said, in some of like the potential costs in the output, or like how much is this helping actually? Is this what we should be focusing our efforts on, or is it not actually making a significant difference? Like,
I don't think people are admitting that they're using it enough yet to be able to do that sort of study, would be my impression. It's sort of like I remember when Wikipedia and Google first came out, and people would say like, oh, you know, any doctor that says they don't look up something in Wikipedia to look up what some condition is they've never heard of is probably lying, because it's like the best way to get like a two-liner about what's happening in some condition you haven't heard of. And I feel like at this point, probably most people, if they're using artificial intelligence, which I mean, a lot of hospitals have come out and said you can't use ChatGPT in your clinical care. A lot of journals have come out and said you can't use ChatGPT to help write your papers. So at this point, I think if people are using it, they're probably not admitting it. I think Michigan now has an internal instance of ChatGPT.
Yeah, I was gonna actually ask if anyone on Zoom knows, I was in a clinic last week and one of the docs was saying to another doc, oh yeah, and we get AI tomorrow.
Mhm.
Docs have access to.
For what purpose?
Yeah.
Okay. So to draft responses? And Greta, I don't know if you have anything to add to that, if you're on.
Yep, I am on, and I can speak to that. We actually are at Michigan Medicine. We've launched a pilot as of November 1st for the Epic Start with Draft, is kind of what it's called, whereby a portal message is sent in by a patient. Their AI puts it into one of sort of 4 categories, like refill, results, question. I forget what the other ones were, or just sort of everything else kind of category. And then we have a draft prompt set that will run in the background. And then when we open up the note from the patient, there'll be a start with draft written by the AI there for us to choose to either use or just do our normal workflow. And so there are 4 of us that are piloting this in general medicine. I'm one of them. The workflow is a little wonky, so I think it's not the best right this minute because we don't have it in the right place in the workflow. It seems like you almost have to accept the text before I open the chart to know really what I want to say to the patient. And so I just talked with Epic a bit ago. They're going to be working on that, hopefully to make it a little bit more workflow appropriate. but it is kind of amazing. It can do pretty well sometimes, and then sometimes it really just misses the mark entirely. Like I'm Dr. Branford, and I had one where it said the patient was asking for a referral. It says, "I'm sorry, I'm unable to provide that referral to you. Maybe you could ask Dr. Branford for that referral." And so, it's kind of not quite there yet, but it's pretty useful some of the time. And so I think that remains to be seen whether I spend more time fixing up the draft, or whether it's quicker for me to use a quick action, or just sort of a few characters for the patient as opposed to fixing up the draft. And so that remains to be seen. The other thing that we are looking into is ambient documentation, and some of the newer companies like Ambiance and Bridge are using GCP in the background to do the work of what many companies had been using as a human scribe, to kind of make sense of the note after all of the recording and sort of voice recognition had been done. So we're looking into that. It was actually quite slick when we saw a demo of that.
Is this the one that sits in the room and listens to the patient-doctor conversation and then summarizes it?
Yep, and we had a really convoluted, complex. We threw in a couple of odd stories on the side, and it put things into pretty good little buckets that formatted into a SOAP note, and had pretty good what we would call meat in terms of like documenting the assessment and plan. And so that it did at least as good of a job as my human scribe. And so if we can get that to work and have it be cheaper because there aren't humans in the background fixing up everything, then that might be a huge one.
I think that at Boston Children's, they piloted that in the sports medicine clinic. And I think the complaints there are a little bit more focused, like you were saying, at least for starters. And then I was told they were going to potentially offer us, at least in a trial, to try it in the emergency department. It's sort of interesting because when we did our mixed method study of looking at the resident node and having artificial intelligence condense it for the attending note, what some of our attendings told us was that just doesn't sound like me. That's not a word that I would use. I would be more comfortable using it if I could sort of train it to use my types of language. Like it would say something like, your loved one presented with abdominal pain, and this attending said, I would never say something like that in my medical note. So it comes out a little bit.
That is definitely one thing we noted with the Start With Graph. It is far more verbose and nicer than I am in terms of like, thank you for asking, and it was so good to see you the other day, and I'm so sorry that you're feeling poorly, and like I would just be like, stay on your same meds, see you next week. And so I think it's much more effusive and wordy, but we may be able to tone that down a little bit. We had to tell it not to stop being friendly, and we instead told it to be concise. So we're still working out our prompts.
That's good. Yeah, I think like the one time I messaged my primary care doctor was when I had COVID like a year and a half ago, and I was asking, should I start on this medication or not? And I said, I'm inclined not to because it's day 5 already of symptoms. And he wrote back, agree. And I was like, that's just what I wanted to hear. It's like a perfect response. He didn't ask how I was feeling or was I out of breath or anything. It was like very concise.
I think one of the challenges I've experienced in trying to solve problems in the health system is we tend to think big. Like I want to fix, I think our first time we talked about, we want to reduce length of stay or left without being seen in the emergency department. And sometimes fixing that thing is really hard, but in part because it's not one thing. So we might not be able to solve that, but we might be able to solve the left without being seen because of social reasons. My kid has to be met at the school bus. I have to get to work, whatever, which is really different from left without being seen because the people around me are hacking up a lung and I'm afraid that I'm gonna get more sick being here than not, which might be different from a third circumstance. And so to help us sort of shape our guidance, I think documentation is a big bundle, right? for the sake of today, could you pick something relatively narrow
Mhm.
with the goal being, I love the iPad example, like, okay, and this is my take, that there's a lot of stuff before we get to really deep neural network, fancy kind of stuff. There's a lot of sort of basic decision tree things that we're not taking advantage of. Like, if the word refill is in the note, put it in this bucket and do the other ones first. Is there something you can think of in particular? I think we spend a lot of time thinking about primary care and portal messages and everything else. Can you like pick a good juicy, good luck on your exam? Can you pick a more manageable bite that we could give you some flying monkey ideas about?
Yeah. I think for me, one of the real frustrations and sort of pain points is having to tell the same story about a patient over and over again to multiple people. And, I'm telling, let's see, so I might tell the story to the primary care doctor who wants an update. I would tell it to a specialist who I want to consult on the patient. I might tell it to a phone consultant who might not actually be coming to see the patient. I'm telling the family at the end of the visit. If the patient gets admitted, I might be telling the same story again to the inpatient team, but then the patient got sicker and now they're actually going to a different inpatient unit. So they have to go to the ICU. So now it's a different doctor I have to sign out to.
I had my question, and then halfway through you said something that pushed me a little bit off that question. So what I was gonna ask is, are you literally telling those different people the same story, or are you kind of shaping and shading it in different ways? And then you said family, and I said, well, obviously he's not using the exact same words and the exact same description of maybe the same issue as he would in passing the patient off to a specialist, right? But is it a matter of, CCing a bunch of people in the same email, or are you like rewriting the body of the email slightly?
Well, right
depending
now,
on where it's
right
going?
now it's not an email from the
Well,
ER.
yeah, I don't
but yeah,
literally mean an
but
email.
that's
I'm
part of
just
the problem.
making
Right
an
now,
analogy.
it's I have to page them and then they call me back and then I tell the story, which is, I would say it's like 80% the same, depending on who I'm talking to. And then, and this patient's diabetic, can you help me figure out how to manage the sugars? Or this diabetic has right lower quadrant pain, I think it's appendicitis, you're the surgeon, can you come down and evaluate them? So the first 80% is the same about the past medical history and the history of present illness, but then you're telling that first 80% multiple times.
You're next, right? Just be warned.
Okay.
So what I'd like to do is, just so students I tend to go in order for a little while, so students have some preparation time, but question or idea, no question's a dumb question. Somebody should ask what mixed methods is, because if no one asks, then I'm going to assume you all know what mixed methods are. And there's no reason why engineering students should necessarily know what mixed methods are. And therefore I'm going to bust you on it. So Gabe, I just gave you a freebie, but we're going to come this way initially. And so our goal is that Dr. Fine walks out of here going, oh God, I don't know why I didn't think about that. And technically, they didn't patent it. So I can make a fortune on this in addition to making my life easier.
We'll collaborate.
So Iman is going to buy you a little time, Gabe. So go, Iman.
Dr. Fine, I like you talking about how you're using kind of tools to solve these variety of problems in the medical setting. I wanted to ask if you were looking into or have experience or have any ideas about tailoring this obviously new tool, artificial intelligence, towards the medical field. I'm paying $10 a month to Khan Academy for their version of ChatGPT, which is extremely streamlined in the tutoring area, which eliminates a lot of hallucinations, a lot of errors, a lot of the stupid literal lies that ChatGPT will tell you, because it's just at the end of the day not perfect. Khan Academy's version is basically perfect for what it tries to do. Have you thought of looking into a medical version that would eliminate all that, noise and be able to get rid of this physician burnout, not having to explain it, okay, translate it back, but it actually knows already to double, triple check it because it's trained on so much more medical data than it is, other random stuff.
Well, I'm interested to see what happens here with sort of the playground version of it with the test version. And I think Boston Children's has also just recently in the last couple of weeks gotten a version of that I haven't actually tried because I just found out about it right before I came here from one of the informatics people. But I am a little bit surprised that that the paid version is better, or is it just that it's a Khan Academy version with it's more tailored to their content?
Yeah, it's just Khan Academy using the engine, but it's its own thing. So it's not like I'd say it's like an extension of ChatGPT, but it really is just Khan Academy.
Yeah. So the thing that I found is that even within there were some basic things that were wrong. Like it got the patient's age wrong. For one example, it was making up references when we asked it to, for one thing, we asked it to come up with a list of references for something, and it just confabulated a reference where it put together two researchers who conceivably could have collaborated on such a study with such a title, but the study just didn't exist. And it's a journal that they probably would have published in if they had written such a study. So it was very, very believable. And that was a little bit scary, I think. Some of the other errors that we came up with, while they may not have been an error, it was using the wrong words. So for example, for an asthmatic, one of the important parts of the history is, has the patient ever been intubated? Because that gives you a sense of how severe their asthma is. And in this case, the patient wasn't intubated, but they had a nasal cannula in just to get a little bit of extra oxygen. And in the patient summary, it said that the breathing tube had been removed. And so someone reading it would have thought the patient had been intubated, which is much, much, much more serious than having a nasal cannula. And so that's something that we could say, why did you think this patient was intubated? And it was sort of a generic answer, like, well, I'm not perfect and I do make mistakes. And it's important that you check before you make clinical recommendations. But I'm looking forward to trying the Boston Children's version and maybe see if it trains it more specifically on our patients.
So Gabe, how are you going to keep Dr. Fine from having to tell the same story over and over again?
Well, so it sounds like kind of a simplistic question, but I guess I'm wondering what's stopping it from really being one write-up that you can just hand out to each person, and as the case evolves, maybe you just add on a paragraph for if their symptoms evolved, or if now you were saying they need to get sent to the ICU. I guess, is it what makes it have to change for each person that you're giving it to?
Yeah, that's a good question. So right now, I'm a little bit limited by how I send the message. I send it through a text through a page. And so I'm typing it out. And then I find that when they call me back, I'm telling them the same story. So I can't put I guess I could put the whole thing in text. It's limited. The number of characters is sort of limited that goes into the text pager. So I'm having them call me back and then I'm telling them the story. But maybe creating a document and sending it to them would be the way to do it.
Yeah, in my mind, I guess it sounds like the issue is there's so much documentation going on. And so it seems like that should also be solving the problem that oh, everything's written out. So now I can just send it over. One other thought I had was you talked about using ChatGPT as a translator in terms of language, but maybe that could also be used to help it fit the recipient. So whether you're giving it to the ICU team or to the family afterwards, maybe if you have that one report, ChatGPT can be trained to translate it in a way that would fit the recipient.
Right. That's a good point. So you could say for the ICU, we're talking more about the ventilation settings and the cardiopulmonary status, but for the endocrinologists, we're more focused on the labs. Great point.
Eve, and then Anjali, and then next to Gabe. So just so you have a heads up.
In terms of how different this write-up is from the notes that you're taking, are they happening in parallel? Does one happen after the other? And if the notes are happening at the same time, that you're taking down patient age, patient past history, all this stuff, almost having an autofill feature of you have the note that you're going to send out to the people that you wish to talk to, be it the specialist, family, whatever. And then as you're typing in your notes, it should be able to read, maybe you have separate lines for each item. Is it could it be compatible where as you're writing it up, it's autofilling the correct thing? So for example, if you're talking to this surgeon, you're oh, this person has abdominal pain, appendicitis, do you want to come evaluate it? it would take that information, but if you're writing it to the family, it wouldn't mention possible appendicitis.
Yeah, right. You should see a surgeon.
It's like, so is
Right.
the note that this like letter, the story that you're writing, is it happening parallel to your note taking or no?
It is, yeah. So I'm documenting as I'm making these phone calls. So I'll say, oh, I'm gonna page the surgeon now. While I'm doing that, I'm gonna update my note. There may be some things that I would say to the surgeon on the phone that I might not want to put in my note too, which is another nuance of it. I think like there's, like you're saying, like the patient should hear everything, but sometimes there might be things that you don't necessarily, you could say like, oh, this family, they've been here like every day for the last 4 days. They're like very frustrated. I wouldn't put that in my note. But that might sort of explain to the surgeon why I want them to come down. Like, I don't actually think it's appendicitis, but they're here again, you better come back again and sort of, help me convince them that it's otherwise or something. So, but overall, the answer to your question is they're happening in parallel.
So if almost maybe if you had like, almost like kind of like a tree, so like you're writing in like the trunk or like the root of it, and then depending on what it is, if you had like something like AI, it could sort of filter out like, is this necessary for the family to hear? Is this like sort of simpler, or is this more like technical medical jargon that maybe the specialist needs to hear, and having it sort of like auto-filling multiple things at once?
Right.
That whatever, like for example, if it's a specialist, maybe they have access to it and they can almost like watch a live update as they're trying to like make their way. If they're in OR, they're like, oh, I need to get to you in the next 15 minutes. And as you're writing, if this situation evolves, they have access to it.
So maybe there could be different templates based on the consultant that you're using. So there could be like a surgical template and an ICU template and like a family template. Where we sort of give prompts and say, this is the information that should be included in this type of template.
Yep.
Like that.
So I'm gonna come to this back row again, and I wanna work on our biases, right? Doesn't have to be ChatGPT.
No.
Doesn't have to be AI. It could be written or spoken or recorded. Like my first thought was, well, why don't you record the conversation with the first doc and then just like forward that text link to the second doc, right? So again, the thing that we think of might not be the thing, but it is sometimes the thing that makes you think of the thing. So you have to put it in your own reference, okay? So you guys we're gonna move out of medicine for a moment. So something's happened, and you have to tell your IOE 813 professor about this thing that's happened in your life. And you also have to tell your roommate, and you have to tell your best friend, and you have to tell 3 other professors, right? And I know for me, part of the problem is I think I start hallucinating a little bit. I start embellishing. Like, I think sometimes you start adding in facts, and I start to wonder, like, was that actually in the original story? So what could you do so you don't have to do the same thing over and over again? Crazy monkeys. You can have your monkeys be like carrier pigeons. So instead of a text, your monkey would fly the document. But I already used that, so you can't use that. Sorry. What are you gonna do?
Maybe I just like one paragraph and then just copy paste and express it to all my friends. And so for the AI, I think there is a tool can help us to like, you can like talk every words to that AI tools, and it can help you to like produce the title and the highlights, and it can give you a bullet of your your key points. And I was wondering like if it can help us to use it in the healthcare industry, because I just use it to help me to help me like study, but I'm not sure if this tool can use in the healthcare industry.
Okay.
What you got?
For me, if I would need to inform multiple people, I will drag them into a Zoom meeting together, just tell them at once. Because I feel like if you need to like call each consultant or doctors, I feel like you can like firstly send out them the documentation, but they definitely have a lot of questions regarding that. So if if possible, like to let them to schedule a meeting together, just like tell them at once. Yeah.
Is there a way, so I like that. I think in the ER that sometimes might not be as easy to do because everybody's running around seeing everybody, so trying to get everyone to come at the same time. But is there a way for me to record it on Zoom and then they can just watch it? Is that what you're saying? Or do we all have to be in the room at the same time?
Yeah, probably like recording will work like a real time Zoom meeting of like both accounts.
Maybe I can just take a video of myself with it and then
I'm thinking about like
Instagram.
cancer boards, or there was years and years ago, we were involved in a project that had to do with children with very, very rare genetic conditions. And so first of all, you would frequently have multiple children at the same time because a family might diagnose one child and now you do genetic testing on their siblings. And so now you might have multiple children, but you want a rheumatologist and an endocrinologist and an oncologist and something. And so they had set up like Tuesday mornings, the first Tuesday of the month, you get all 8 providers or whatever it was in one place at one. So instead of saying like, okay, your appointment with the rheumatologist is on Tuesday, and then the following Friday you come back. And, you know, it is interesting to think about, could you sort of say, okay, it's very common for us to need these 3 specialists at the same, for the same patient. We set up a once an hour, you get all 3 in a quick succession or something. But I think that idea of, do you ever have the surgeon says, well, what about this? And then you go to the endocrinologist who says, well, the surgeon needs to do that. And like you're playing the telephone connector.
Or somebody's just saying, what's your question? I don't understand why you called me. You know, that sort of thing too. That happens too, because the other thing is in a teaching hospital also, I might not be making the call all the time. It might be the resident or the fellow. And it's possible that the resident and I haven't really connected on, I might have said consult surgery, and they might not know why they're consulting surgery, and they might be afraid to ask or something like that.
Slack. Doesn't he need a Slack channel? You know what a Slack channel is?
I have used Slack, but it's been a long time. How would that work?
It's like a group chat.
There is secure chat.
Because if you put the thing in Slack, and then this is me explaining Slack, Tom would be horrified. But if you were to put the story in Slack and like ping the endocrinologist and the oncologist and the whatever, and now the endocrinologist says, but what if like, well, did you check this? And your medical resident might also be in Slack, and they could actually go check this before you even got a chance. And then the surgeon might jump in and say, well, if you're checking that, you should check this too. And I mean, to me, Slack is just the thing that you have running in the background all of the time. So you're just constantly kind of, okay. Problem solved, Iran. You nailed it. Iran wins the Flying Monkey Award today. Okay, we're gonna go to Iman, and then we're gonna come over here. And then I'm gonna check the Zoom.
One of my favorite Twitch streamers, he had like this big operation on his face. So he's wearing this like weird mask. And when people would tune in to watch him, they would always like ask him like, what's on your face? What's on your face? And he'd explain it. But then he realized like people who came in would ask the same question. You have to keep explaining it. It's like, so he made a button that would produce the same coherent, smooth speech. And every time he got it, he would just click the button and it would just replay in the stream, which I thought was funny. Like if you're actually watching it and hearing him click it multiple times, I thought of, you know, you said carrier pigeon, right? Like get your speech out on a button and go like toss it to your friend or like give it to someone who can give it to the guy that you're going to talk to in 10 minutes. So he's already up to speed. I just thought that was a funny application of like a carrier pigeon, but like actually maybe not the worst idea.
Well, actually, yeah, if there was somebody else that could actually put the page in, like if there was a medical assistant or someone that could put, I say, here's my spiel about this patient. Can you send it to the following 3 people and tell them to call me if they have questions, or else come and see the patient, or send me their recommendations on what they want me to do.
Hi. So I have a question first, and I guess I'll give my idea. So like, what kind of technology are you using now to communicate? When you say like a pager, I'm thinking like the 1995, like, you know, like, what's the actual technology that you're working with?
There's a couple, actually, some of the pagers do hold some of the residents do hold a pager. So we carry a code pager. And a lot of the consultants carry an old pager that basically has text messaging on it. And then that's the pager that we have.
Okay, so yeah.
What else beeps, and if you remember to have it on you, if you didn't leave it in the call room, it beeps, you push the button and then you're like reading it, like it says like ER 13-year-old right lower quadrant pain, come see patient with a callback number. Or we can actually, there's a messenger app. We all have phones that we carry around, hospital issued phones that we carry around. And so that one you could put in a longer text message in that one.
So I guess my idea, I was trying to like build off with the AI. I guess you could like, so the AI would do like a, you know, maybe in the future, pretty good job of like understanding the SOAP note and like what the patient, you know, what you wrote down for the patient or what it already transcribed. So you could like send a pager to the other doctor that you'd be working with and say, like, have the patient will have like an ID number, right? So he can call you up, and if you can't reach you for whatever reason, like you're busy, you can like input the ID number, and you know, ChatGPT or whatever kind of like text to speech over the phone would like kind of relay what the you know, what he would need to know. And with AI, kind of like expound on any questions that, you know, the doctor might have. So there would still be like, he may try to reach you over the phone, but AI might be like a stopgap to kind of fill him in when he can't reach you.
Is the ID number the medical record number, or is that the like the ChatGPT or AI number that's gonna link to my description?
I mean, either one, I suppose, like whatever, like, so you would send some kind of ID to the other doctor that he would use to identify. So like he would have an ID, so the system could recognize that he's somebody who actually like needs to know this information. Then he would have his information that he puts in to pull up the record that he's looking for. But I guess you like send him that ID first.
Yeah.
And he would just, you know, retranscribe it into the phone, kind of like, you know, put in your social security number to, you know, get your banking information.
Right.
And then so like ChatGPT would be like or whatever AI is being used would be like a stopgap to just kind of help you when you know, can't talk to him directly.
Right. Go to the medical record and read about it, because they can get into the medical record and read it. They can get into the same medical record.
And then like, I suppose like in the system, each doctor ID category could recognize like pediatrics versus like emergency versus like primary, and then it would direct him, you know, it could tailor the information depending on where they're working, something like that.
So I want to make sure that everyone gets their question in so they actually get credit. So the students taking the class have to actually speak. So those of you who haven't spoken, I'm going to give you your chance. So I'm going to go to you, and then I'm going to come down here, and George, you'll be at the end. But that way you have lots of time to think about it, but all the good ideas will be taken. So go ahead.
I have a question and idea first time, but the question is, so when you're a patient, you go to the ER and you tell the check-in person why you're there. And then you go to triage and tell the nurse why you're there. And then your clinician comes in and asks why you're there again.
And then the med student, then the resident, and then the fellow.
You want to hear it firsthand from the patient, but do you think that the other people who you speak to will also want to hear it firsthand versus getting a message?
Right. Okay, so we actually put in an IRB about a month ago, and we got like, I've never seen an IRB review. There's 12 pages of comments and critiques, because what we thought we would do is hand the patient an iPad and interact with the patient, say, why are you here today? And then sort of go back and forth and trade it and say, oh, you have a sore throat. How many days do you have fever? And then have artificial intelligence summarize it. And then say, it's all dead time. It's while you're waiting to get into a room, you'd be interacting with this tablet. And then we would sort of compare that to the history ultimately taken by the doctor and sort of see, like, did it miss anything big? Did it hallucinate, confabulate? So we weren't able to, so we're trying to revise the IRB, and one of the critiques was that you can't use ChatGPT yet until we have like an internal version, which is now available. So we're going to try to do that, because it's super frustrating, right? To tell the story, and the doctor comes in and they say, why are you here? Or like, what medicines you're on? Or like, oh, it's all on the chart. I already told somebody. Like, I don't feel like saying it again. Right? So it's like the reverse thing of what I was saying, having to repeat my story to the consultants, right?
Don't you think there's a benefit because then you have that conversation and hear it again and then can fill in some gaps.
It is. It's like every time you tell the story, you get a little bit more information and you like refine it in your own mind. You think of other things. So
Greta, I'm gonna get you after I get to the end of the students. So we're gonna come to you next. Yep. Yep.
So I have a really crazy idea. So I'm thinking about if you can create the like virtual version of you by feeding those like personal sounds, you know, the knowledge of like the with those details about the situations of patient, of like maybe you have a certain several case on hand, just put all the information of those cases to this AI, with those like tailored model. And then the version of you will like talk to other, you know, patients, you know, other surgeons, like in behavior and making a real phone call through like internet call. So I like, because this kind of version of you has your sound, they may not know that is not you. So they will ask you some question.
So it's based on the way I've managed patients before, based on consults I've given before, it's gonna tailor it towards this consultation.
It just depends on how well this model is.
Yeah. I like that. I'm gonna freaky, but I like it.
Just an avatar.
Yeah.
Go ahead. What you
Great.
got?
Struggling. The only thing, and my experience was, I worked on cancer teams where tumor boards are common, and you referenced that, and that's what came to mind is tumor boards. Every Friday morning, they come all together as specialties, and I was trying to think of how to replicate that in an ER, in the context of ER, which is very, very different. And there's like the element of urgency. And sorry, it's not really, I mean, just I think your idea is great, this Slack idea, having to write that once, the summary, just type it once, and then pinging all the relevant providers on there, just like what she shared. Yeah.
It would be great to have everybody in the room at the same time because, you know, the surgeon may say, oh, the urologist doesn't need to come. I can handle the whole thing. And so the last thing we want to do is make more work for other people that don't need to be involved. But sometimes in the ER, I'm not really sure. Should I be calling the surgeon or the neurosurgeon, for example? Like, I'm not quite sure. So I'd call them both. And now, like, all of a sudden, two people are coming down, spending time. It's more time for the patient. I'm getting two separate sets of recommendations.
And they don't necessarily know you've called each other.
Not necessarily.
And they could actually be together.
Yeah. And they could say, I'll handle it. I'll let you know if we need neurosurgery involved, for example, that sort of thing.
Do they charge for all these? It's a silly question. Do they charge for the time? I'm sure they do, right? When you consult different specialists?
It's sort of complicated, but I think in the emergency department, it may be folded in. It probably depends on their insurance and also whether or not the attending physician actually comes into the ER. Because a lot of times at an academic place, it may be the resident or the fellow who does the consult, and the attending may be available by phone. But if they haven't seen them in the ER, it may not be separately charged. Sometimes yes, though.
All right, we're gonna do 4 more students and Greta, and we're gonna call it a day. So kind of good stuff. Good stuff.
I'm wondering, like, are you confounding quantity with like complexity of this stuff? Like, I feel like there's a lot of quantity of stuff in the EHR for you, and so that's a problem also, like combined with the complexity of the information you're getting. So can you use AI for the easy stuff as like a screening measure initially and like give it the stuff that you know it can do, and then deal with the complex stuff yourself, the stuff that you're not sure will lead to hallucinations or incorrect output? That's just my thoughts.
Great point. I like it. So in the mixed methods study that we did before, we had 2 simple cases and 2 more complex cases. And it's interesting because some of the docs said, like, I like it for the complex cases because it condenses it a lot. And I don't really need it for the simple ones because I can do those myself. But I see it your way too. Like the simple ones, I'm seeing 20 cases of patients with runny nose and sore throat. Wouldn't it be great if I didn't have to do the same thing 20 times in a row? If I could get some help with that, and then I can focus my time on where like the patient actually needs me a little bit more.
Go ahead.
Is it possible on like the patient's chart, but from the provider's perspective, to like have a chat on the patient itself's chart and like you can ping certain professions on the chart and they can look at the patient's information. They can look at like what comments you've entered like during the day, and leave their comments and like kind of like a group chat on the chart, because that's something that's possible.
That's a good question, and we're moving into Epic in May, and I do think that I don't know if there's a chat feature, but I know that you can share the notes with other docs, but I don't know if it's in real time.
So there is a chat and you can see pending notes as well. So you
Okay.
can go in and like, if you call a consult, they might have read your pending note.
Okay.
But the chat is really bad. Like the chat is not like, you can't necessarily see all the active chats that are going on about a single patient, and you have to add people. So
Okay.
like if you start chatting, let's say like the surgeon, and then you want to get the urologist on board, you'd have to like, someone has to like think to add them. And then if the teams flip over, it's not service dependent, it's the individual people. So that if the, night teams went like signed off to the day team, then like that's a hot mess.
Or did the person who signed out to you tell you about the chat?
Yeah.
Or what chat? Yeah.
All right, two more and Greta, and we're home free.
So I'm just have like a comprehensive kind of questions. So I think most of the questions are related to data analysis and some AI stuff. So I'm just wondering for as human beings, I still think that we are kind of smarter than ChatGPT most of the time. So would it be possible for us to kind of write some coding stuff to kind of clean up the data by the patient's medical record and something, so that I don't have to do 20 times of the same symptoms? So kind of you clean up the data, and once you are cleaning up, you kind of put all them into Excel, whatever, and then once you have those files, you send them to AI, and AI can kind of quickly generate the most important symptoms or the causes for these patients, and then give you a feedback in a most efficient way. So I was thinking like you combine your knowledge or your way of doing data with AI instead of you relying everything on AI.
Jared, what you got?
I'm gonna put another bid to like the idea of like you said like 80% of the information that you repeat it to like the different doctors you need to speak to. If you like on your like computer, when you're capturing that information, you have the 80%, you pick where it gets sent, and then you have like variable information that goes to like physician A versus physician B of what you think might be the cause and like what is relevant to them. And then that's like the idea. And then my question is like, where do medical scribes fit into your work? Is like, if you said you're doing most of like the data gathering and typing it down, like if you had like our scribes still around, and like if you had, your scribe could do that, talk to this person, do the talking for you so that you could like focus on talking to another patient.
Yeah. That's important. I think we were pretty close to getting scribes, and for the first time we were gonna have scribes, and we were gonna use them actually for the more simple cases, so that way I could just run from room to room, see the patient, have someone follow me around and sort of handle that. Then it turned out there was a scribe shortage, so we got slashed. But I do know doctors who use scribes, and a lot of ERs use them too. And I think if you work with a scribe for a long time, it's highly effective. So I think that would be a potential another solution to that as well.
Greta, if you want to have a question or a comment from Zoom.
Yeah, just on that last comment about the scribe reaching out or something along those lines, I think you guys aren't in the whole medical establishment as much in terms of hierarchy, et cetera. There are sort of unwritten rules also in terms of like, maybe you don't have the medical student calling the attending on call, like, because they're not going to have a full enough story, and that's sort of like jumping a couple layers. Similar thing for the scribe. I think it would not be like really, the scribe doesn't have any medical knowledge to speak of. And so having them try to pass off information to another medical professional would be deemed, I think, just sort of unprofessional and not really very appropriate. Just to give you context on that one. But I really was just kind of want to commenting on the larger overarching garbage in, garbage out, and what we see a lot of times in the medical record. And what it brought to mind when you were saying that the patient gets tired of saying, yeah, I said yes, it's already in the chart. Yes, I'm on these things, I cannot tell you the number of times, it's probably 80% of the visits I see where the patient has checked in with the portal and they have to click through their meds and they have to say exactly what meds they're taking. And then the MA comes in and says, oh yeah, are you taking all of these medications? And it's not until I go over every one of them exactly and say, okay, this one is your this, and are you taking it for this? And you're taking it twice. Say, oh no, I stopped that because I ran out and I didn't know I was supposed to get more. And are you taking this one still? Oh no, that one caused me to have a rash. I'm not taking that one anymore. So it's not until I get into the nitty gritty in the room and talk with them about each medication specifically that they bother to even let that enter into their realm of what they want to report. And so that's a very common finding. And so not only is there chart lore and like sort of, just there's a lot of clicking next just to get checked in without patients actually looking at the information that they're like submitting.
Thanks very much for that, Greta.
I want to add one more comment to that because I think the lingo, just real quick, the lingo is so important. Like as doctors, we sort of forget what non-medical people know and what they don't know. Like along the lines with the medications, I'll ask a patient, do you have any medical problems? Or ask a parent, does your child have any medical problems? No. And then you go to examine them, there's a midline scar. They've obviously had cardiac surgery. And you say, well, what's that from? And you say, oh, he had surgery, but it's not a problem anymore. And because I asked, do you have any medical problems? Since they don't really see it as a problem anymore, they said no, but obviously it's like a major factor in how I'm going to manage them after that. So
right. And there's also patient perception, like, we've seen patients, oh, I've got lupus, and they'll tell everyone they see that they've got lupus, but every specialist they've ever seen says they don't have lupus. And so, you kind of get into this like little tug of war about whether they do or don't. But that's where a lot of chart lore and sort of like inaccuracies come from.
yeah, thank you.
A flying monkey, but I have a monkey wrench.
I like your monkey wrench, Renee.
So, spent a lot of time today figuring out different ways of making clinical notes and various asynchronous communications to other physicians and family members, etc., easier to generate. And potentially there's a danger of making them more voluminous because they're more efficiently generated. But I'm wondering to what extent the reason you guys still call each other on the phone is because while you're talking to somebody in person or on the phone, you have most of their attention in real time. And they're actually listening to you and responding and thinking about what you were talking about. And taking it even further, if we are able to make communications more asynchronous and more written and pre-recorded, would it make physicians even more unhappy because it turns out they really enjoy talking about their work with their colleagues and having real conversations in real time. And to what extent are we in danger of taking it away by saying, oh, let's just send this piece of text to everybody by some electronic system?
That's a great point.
I think that brings us to the fundamental, right, is what is it that we're trying to accomplish? And asking ourselves what, right? If your goal is to reduce provider burnout, not taking away things that providers enjoy and find valuable, but coming back as you're trying to fix a problem, make sure you really understand the problem you're trying to fix. So thank you again to Dr. Fine, and thanks to everyone on Zoom and in the room for your comments. And we'll be back here next week for Dr. Ivy. All right.
Thank you.